Hi guys, it's Professor Rich, and this PowerPoint goes over GU and reproductive disorders. Throughout this PowerPoint, we're going to go over the assessment of the renal and urinary function, urinary disorders, male reproductive disorders, female reproductive and breast disorders, as well as STIs. Assessment of renal and urinary system. The renal system is composed of 2 kidneys. The urinary system is composed of 2 ureters, the urinary bladder, and the urethra. The 2 systems work together to help maintain homeostasis in the body. For example, urine is formed as blood is filtered through the kidneys. The bladder then provides storage, and the ureters and urethra act as passages for the urine to exit the body. Thus, the function of excreting waste from the body is complete. The kidneys perform the following functions essential to maintain homeostasis in the human body. 1. Excretion of waste. 2. Regulation of fluid and electrolyte balance. 3. Regulation of acid-base. 4. Regulation of blood pressure. 5. Secretion of erythropoietin for red blood cell production. And 6. Activation of vitamin D. The urinary system provides the storage and passage of urine, promoting continence and facilitating voiding. This chapter first examines the anatomy and physiology of kidneys and then examines the anatomy and physiology of the urinary system. When obtaining a history and physical, you need to get the demographics and personal data. So collect subjective patient history. That's critical in assessing the functioning of any body system. When the renal and urinary systems are evaluated, essential demographic data should be collected, such as gender, age, race, socioeconomic status, occupational history, dietary and personal habits. Personal and family health history. Patients should be questioned about their overall health status. Alterations in functioning of renal and urinary systems can produce systemic effects. Complaints of fatigue, changes in weight, excessive thirst, and signs of fluid retention are all symptoms that warrant further investigation into the function of the renal and urinary systems. Medication use. This is essential to collect within a thorough history of the patient. We need to know current and past use of prescribed and over-the-counter medications, vitamins, and supplements. Renal and urinary assessment. So when specifically assessing the renal and urinary system, question the patient regarding any changes in the appearance, clarity, or color or odor of the urine, the pattern of urination, and the ability to voluntarily control voiding. Inspection. Because alterations in renal and urinary system affect all other body systems, begin with an inspection of the skin, oral mucosa, abdomen, and extremities. Depending on subjective reports by the patient, an inspection of the urethral meatus may be necessary. When inspecting, assess for the presence of the following abnormal changes. The skin. You might have poor skin turgor, rough texture, pallor, a yellow-gray color, flank bruising. The mouth. An ammonia breath odor, stomatitis, which is inflammation and ulceration of the oral mucosa. Abdomen. Uneven contour, unilateral lower abdominal mass, stretch marks. In the extremities, we're looking for edema. On that urethral meatus, we're looking for bloody or purulent discharge, skin lesions or rashes, or any obvious trauma. Auscultation. With the patient lying supine, auscultate over the abdominal aorta and each renal artery with the bell of the stethoscope. When auscultating, listen for a bruit. A bruit is a turbulent or whooshing sound produced by an increase in volume of blood traveling through a vessel or a decrease in the diameter of a blood vessel. The presence of a bruit indicates altered blood flow to the kidneys and warrants further investigation. Palpation. With the patient supine, position lightly palpate in all 4 abdominal quadrants. Instruct the patient to report any discomfort or tenderness upon palpation. The bladder is typically not palpable unless distended with urine. If filled with urine, the bladder is sensitive to palpation and feels round and firm. To palpate the kidneys, position the hand under the patient's flank between the rib cage and iliac crest. Position the other hand over the abdomen just below the rib cage. Ask the patient to take a deep breath and use the lower hand to raise the flank while the upper hand palpates. The lower pole of the right kidney is occasionally palpable in some patients. The left kidney is positioned deeper than the right and is typically not palpable. Percussion. While the patient remains supine, percuss over the symphysis pubis up towards the umbilicus. Dullness is a sound elicited over a distended bladder. A bladder containing little to no urine produces no sound upon percussion. Assess for flank tenderness utilizing fist percussion over each kidney at the CVA. Have the patient return to a sitting position and position yourself behind the patient. Place one hand flat over the CVA. Form a fist and the other, and with the other hand, strike it against the dorsal surface of the flattened hand. This blow to the flank area should not elicit pain or tenderness. If the patient does report pain or tenderness, it is suggestive of kidney inflammation or infection. Bladder and urinary health teaching includes increasing fluid to 2 to 3 liters a day unless contraindicated. Dysuria is painful urination. A patient with dysuria can be given pyridium. This helps with the painful urination. It does not treat any infection, but again, it helps with the pain. If a patient takes pyridium, the urine will turn orange. Hematuria is blood in the urine, or pink-tinged urine. This is expected after a TURP procedure, which we'll talk about later. Anytime dark red blood clots, or bright red blood is happening, that is not expected and it requires prompt intervention. Polyuria is excessive urination. Nocturia is excessive nighttime urination. Urinary retention is the inability to empty the bladder completely. Urinary hesitancy is difficulty initiating urination. Urgency is that feeling of need to void, like right now, immediately. A BUN, blood urea nitrogen, is how well the kidneys are excreting urea nitrogen. A low BUN usually means too much fluid or severe liver disease. A creatinine is high, well, BUN is high as well, but they're high when a patient is dehydrated. I apologize. Is dehydrated, so these patients typically need fluids to help hydrate them. It could also mean a kidney injury. A creatinine is the most reliable indicator of that kidney function, and it elevates when the renal system is impaired, so it requires quick action. Specific gravity, so the higher the specific gravity, the more concentrated the urine is. The urinalysis, it evaluates urine for blood, bacteria, protein, white blood cells, nitrates, and again, specific gravity. The ESR is an inflammatory marker, so this increases in any disorder that has an inflammatory component. For an example, pyelonephritis, which is a kidney infection. And then a PSA, which we'll talk more about later in the PowerPoint, is a prostate-specific antigen. All men have a PSA level. However, if it's elevated, which is a level greater than 4, we're concerned for a prostate cancer or something else is going on. After a TURP, a TURP procedure, which again we'll talk about later, it's expected for that PSA level to be elevated. And then again, prostate cancer is expected. So diagnostic tests within the GU repro system. So a laparoscopy is a scope into the abdomen. CO2 is instilled into the abdomen. The patient's expected to have bloating, shoulder pain, back pain after, and that's all related to gas. To help kind of get that moving, we're going to have them walk, ambulate. So again, this test is used to visualize and assess ovaries, fallopian tubes, the uterus, helps diagnose inflammation, malformation, cysts, fibroids. It can be used to evaluate infertility, and then also if we need to remove something, we can do it laparoscopically. An ultrasound visualizes and assesses solid organs in the abdominal area. So this could be your breast, pelvis, prostate, scrotum, thyroid, or parathyroid glands. The bladder may need to be full or empty depending on what's being visualized. A pap smear is a swab of the cervix. This collects a sample of cells. A colposcopy visualizes and assesses the cervix and vagina related to suspected cancer or other diseases. A cervical biopsy is obtained, typically during a colposcopy. So these are done after an abnormal pap smear. It is a painful procedure. It's a swab of the cervix with a solution, and then they look at it with a light magnifying device. And the sample's typically taken, again, when there's an abnormal pap smear, so there's an abnormal tissue identified. The bladder must be empty prior and nothing in the vagina for 24 hours prior to the procedure. After some bleeding is expected, the patient should avoid strenuous exercise, and this cannot be done if the patient's on their menstrual cycle, so they'd have to wait and reschedule. A cystoscopy with that's not supposed to be, okay. A cystoscopy visualizes the bladder via a scope. The patient may have burning for the 1 to 2 voids after the test. We expect pink tinged urine after this test. So age-related changes. So blood flow to the kidneys decreases. There's a decreased ability to concentrate urine. The pH increases. There's an increasing risk of UTI because of that pH increase. Pubic hair thins. The testicles become smaller and softer. There's atrophy of the penis. The scrotal sac loses elasticity. The skin becomes darker than the rest of the tissues. It's important to know that incontinence and erectile dysfunction are not considered normal findings. So they're not considered expected findings. They're unexpected. Urinary tract infection. So this is infection anywhere in the urinary tract. Inflammation of the bladder is called cystitis. Risk factors: poor hygiene, sexual activity, foreign object, kidney stone, estrogen deficiency, recent catheterization, and diabetes. Expected findings: so they're likely to have a cloudy, foul-smelling urine, burning, painful urination. Their urine might be darker, especially in older adults with dehydration. They may or may not have increased serum white blood cells. It really depends, even with this urinary tract infection. Other symptoms we're expecting: they're probably going to have that frequency, urgency. They might urinate small amounts of time at a time. Suprapubic pain. They have some blood in the urine. Dysuria is that painful urination. Diagnostics going to be a urinalysis, and then complications: acute confusion and agitation. This is not expected, especially in elderly this happens, but this could also be a sign of sepsis. So we want to make sure that we're promptly calling the doctor if we see these symptoms. And then if there's a fever, we want to assess for flank pain, nausea, because then it's likely that the kidneys are now part of the infection. So that it's all attached. It's all kind of a tract together, so it could travel all the way up to the kidney. And then again, sepsis with that acute confusion, but also fever. Their blood pressure could decrease, their heart rate could increase, maybe respiratory rate's going to increase, and then their SpO2 could decrease, and that's as they head into deeper sepsis. So urolithiasis. So this is a kidney stone or a calculus. It's like a microscopic crystal buildup. It's somewhere in the urinary tract. It could be up in the ureter, it could be down in the bladder, it could be in the urethra. So sometimes they're small enough where they could just pass on their own, and other times they're bigger and they cause an obstruction. The problem with the obstruction is, for one, the pain, but also then the urine's not going through, so then urine's sitting there, and an infection starts to brew. So they get urosepsis or pyelonephritis, which is that infection of the kidney. So treatment: we're going to strain all their urine. Our goal is 2 liters of urine output a day until that stone passes. We want them to be voiding a lot because we really want to get that stone moving. Again, a small stone the patient may be able to pass. A 5-millimeter stone, they're going to need a lithotripsy, and that's just shock waves that break up the stone. A 10-millimeter stone is going to be a pyelolithotomy, which is a surgical removal of the stone. And then if there's a severe obstruction, they might need a nephrostomy tube. We need these patients to increase their fluids and avoid oxalates. They should eat a low sodium diet. Straining the urine can be delegated to a UAP. Urinary incontinence. So this is the release of urine unexpectedly or uncontrollably. So this could be related to age because of the loss of pelvic muscle tone. it can cause the involuntary loss of that urine. So risk factors for this are mainly childbirth, smoking, and obesity, and there's different types. So there is stress, which is laughing, coughing, sneezing. Urge, which is sudden onset of I need to go now, so that's that urgency, like I gotta go right now, I'm gonna pee my pants. Overactive bladder, so this is that they waited, overflow is that they waited too long. And then mixed. Treatment, so the surgical is a suburethral sling, which is basically a sling under the urethra that helps support it and decreases that incontinence. Non-surgical is pessary devices, Kegel exercises, and clean intermittent catheterization. Medication for this is sometimes oxybutynin. So overactive bladder is something I want to just add here. So for this, we do expect an anticholinergic medication that relaxes the smooth muscles of the bladder or decreases spasms. So here especially, you might see that oxybutynin given. So an overactive bladder, we do expect that anticholinergic. Bladder cancer. So obviously it's cancer of the bladder. This is the fourth most common cancer, and smoking is the biggest risk factor. So smoking is the biggest risk factor for bladder cancer. The earliest sign is that painless bleeding. Treatment could be intravesical chemotherapy, which is kind of cool. So they actually instill that chemotherapy right into the bladder via a catheter. And depending, they either let it sit there and kind of absorb a bit, or they just put it up and take it out. And then fulguration is removal of the tumor through laser or electrical current therapy. BPH, benign prostatic hyperplasia. So this is non-cancerous in large prostate. It's caused by testosterone or estrogen hormone imbalance. So there's early signs. So early signs are like a decrease in the stream of urine, and then later signs are that stream becomes weak, there's dribbling, they may have hematuria, frequency, urgency, urge incontinence, and nocturia. This also increases the risk of urinary tract infection, because if there's stasis of urine, that's anytime there's stasis of urine or the urine's not flowing, we can expect that an infection, or we can prepare that an infection might brew. So this is diagnosed via a digital rectal exam, a DRE. So basically the doctor provides, or the provider places a finger into the male's rectum to assess the prostate size. He then feels that it's enlarged, and then they'll probably go and do some labs, check a PSA, which should not be high from BPH. Again, that would be high from prostate cancer, but not BPH. And then they would go from there. Maybe they'll do an ultrasound or something. So treatment, so watchful waiting. This is when the doctor feels that enlarged prostate and they confirm it's that BPH, but the symptoms aren't interfering with the patient's daily life. So the patient, he just went for his regular physical. He's now diagnosed with BPH, but he's still voiding fine. He's not having any issues really. He's just living life. Medications, and this is for someone that's having more of an issue. So alpha blockers like finasteride and tamsulosin. And then there are anticholinergics, but again, this really depends. They're not a first-line treatment for this, and that would be the oxybutynin to relax bladder muscles. But anticholinergics aren't a first line and are sometimes contraindicated with BPH. Surgical is going to be that transurethral resection of the prostate, which is that TURP procedure I mentioned earlier. So with that TURP, excuse me, after we do expect the patient to have a three-way Foley with continuous bladder irrigation. So that's CBI, which I can show you in class. A CBI helps flush out the bladder and the urethra to move any blood clots. We do expect pink tinged urine. We expect the patient to complain that they have an urge to void even with a catheter. We expect the elevated PSA. We do expect that after surgery. What we do not expect is a fever, bright red blood clots, dark red blood, anything that is not just that pink tinge. We're not expecting. We need to call the doctor, because all of those mean that fever means infection, and all that bright red bleeding, dark red, and clots means that they have an active bleed. We need to call the doctor now. And I mean, you can also increase your rate of your CBI, but again, you need to call your doctor and talk to them if you're having signs of active bleeding. For these patients, we need to avoid decongestants because they cause an elevation in blood pressure and they can actually cause urinary retention. And again, that's where the anticholinergic contraindication comes in. Erectile dysfunction, ED. So this is the inability to achieve or maintain an erection. It's typically a blood flow issue and it's not considered a normal part of aging. So diagnostics, we're going to get a patient history, which is subjective, and then we're going to consider assessing the blood flow via vascular studies like a Doppler. They're going to need a cardiac workup prior to starting any medications, as they can decrease the blood pressure. So the most common causes are going to be smoking, cardiovascular issues, obesity, stroke, spinal cord injury, neuro disease, diabetes, liver, kidney, decreased testosterone. Substance abuse is related to like 25% of the cases. Treatment, so we're going to have that Viagra, and then there's other medications and different treatments like the vacuum device, surgery. And then also make sure you're using therapeutic communication with these patients because they can be very sensitive about this. Testicular trauma, I'm just going to quickly go over this. So types, we're going to have blunt, degloving, penetrating. Common injuries are sports related. The treatment, we want to be as conservative as possible. So NSAIDs like ibuprofen, compression and scrotal support. Make sure it's not too tight, but we want it supportive like cotton underwear. Ice therapy, rest. And then in severe cases, they might do drains to help decrease that swelling. Okay. All right, prostate cancer. So obviously, cancer of the prostate. This is slow growing and often unnoticed. Risk factors are African American, age greater than 64. Again, as usual, a diet high in red meat, and then also a high BMI and a diet high in calcium. Diagnostics going to be that digital rectal exam, and then a PSA greater than 4 is concerning. Treatment, chemotherapy, radiation, cryotherapy. Prognosis, this is typically a good prognosis. It's usually curable. Testicular cancer, so obviously cancer of the testicles. Signs is going to be a painless mass, swelling, hardness of the scrotum. Sometimes they might have a dull abdominal pain. Diagnosis is typically a self-exam, ultrasound, and treatment's going to be chemotherapy or surgical removal of that testicle. Breast cancer. So this can occur in males and females. The breast exam can be self or provider performed. For provider or nurse performing the exam, the patient's to lay supine with the arm of the breast being examined above their head or hands resting behind their head. During this, so if a patient has metastatic, which I know we talked about in week 1 or week 2, the goal is to offer support, pain management. The treatment for breast cancer could be supportive, radiation, chemotherapy, or surgery, which can include a mastectomy or a lumpectomy. Make sure that you don't use the arm of the affected side after a mastectomy. So if the right breast was removed, do not perform a blood pressure, blood draws, medication administration, etc. on that right arm, and vice versa if it's the left. Therapeutic communication is vital for these patients. Make sure that you're supporting the patient's goals, whether it's to fight terminal cancer or to choose not to fight when the cancer is treatable. So just make sure that we are being very supportive of these patients. Dysmenorrhea, this is a painful menstrual cycle with severe cramping. It's typically worse when periods start at a younger age and they get better as that female ages. There's not always an identifiable cause. There's different ideas of what it could be. It could be a buildup of fatty acids in cell membranes after ovulation. It can be related to prostaglandins. Those are what cause the contraction of uterus and blood vessels, which can cause pain, blood clotting inside the uterus. And then to treat it, it's usually NSAIDs, oral contraceptives, heat, and exercise. We recommend exercise for that. So hormones that regulate the menstrual cycle are estrogen and progesterone. These are from the ovaries. When entering menopause, a lot of patients are having these hot flashes and they want to learn how to manage them. We're going to recommend black cohosh. This is the most common herbal recommendation for hot flashes. Endometriosis, so uterine glands exist and they grow outside the uterine cavity. This can be very painful. It can cause infertility. Treatment's going to include contraceptives, laparoscopy, and hysterectomy in extreme cases. We need to make sure with these patients we are using therapeutic communication. This can be very traumatic for these patients, especially if they are infertile. So therapeutic communication, again, is very important, especially when family planning is failing. Fibroids, these are benign tumors in the pelvis. They can be very painful. It's a leading cause of hysterectomy. Treatment's going to include hormone therapy to shrink them, tranexamic acid, gonadotropin release hormone, again, fibroid surgical removal, and then hysterectomy in those severe cases. Ovarian cancer, this is cancer of the ovaries. Treatment's going to include chemotherapy and surgery. If we remove the ovaries, patient will likely need hormone therapy of that, what I mentioned earlier, estrogen and progesterone, because they are from the ovaries. So if we remove them, we need to replace them. Cervical cancer, obviously cancer of the cervix. So a pap smear is typically our best way to kind of learn if the patient has these abnormal cells, and then they go for that colposcopy with the cervical biopsy. Pap smear should start at the age of 21, and then if it's normal, we can recommend for 3 years later. I know a lot of us, it becomes that yearly pap smear. Treatment for this will be chemotherapy, radiation, and surgery. HPV, the human papillomavirus. So this is going to be our first STI that we're talking about. It's sexually transmitted. It is very common. I think they say like 80% of the population has it. There's several strains from low risk to high risk. The high risk are the cancer-causing strains. Usually no symptoms, but it can cause genital warts. The genital warts are treated with topical creams and gels. We should know what these genital warts look like and compare them to genital herpes to see the difference, and I can show you that in class. So we do recommend vaccination to prevent HPV in females. This starts at 9 years old, but should be given no later than 26 years of age. There are pregnancy complications and considerations. The vaccine is contraindicated in pregnancy. Creams, gels, topicals are contraindicated in pregnancy. And a C-section may be necessary if there is a genital wart outbreak during delivery. But that's something that the doctor will discuss with the patient. Us as nurses do not discuss that with the patient. Syphilis, so this is a sexually transmitted infection. This could be acute or chronic, and there are 4 stages. This can be dormant for years. Syphilis that leads to a rash and lesions that could be macular, popular, or pustular. The rash is commonly on the palm of hands, soles of feet, buttocks, and upper thighs. The number 1 treatment, or the first-line treatment, is penicillin. However, if the patient is allergic to penicillin, the secondary choice will be doxycycline. Genital herpes. So this is a sexually transmitted infection. This is viral. So this can be transmitted even when an outbreak is not present. Condoms will not protect from this infection. It presents with vesicles that are usually painful and itchy. The patient might also have flu-like symptoms, fever, headache, myalgias, dysuria, burning, and itching during an outbreak. For the treatment, so first off, this is not curable. You have it for life. Acyclovir is an antiviral. So this is something that we want the patient to start in the prodromal phase, or the phase where they kind of have a warning sign. If you ever have had a cold sore and you have like a tingling on your lip and then the next day the cold sore pops up, that tingling is that prodromal phase.
same idea. So we want them to start the medication, that acyclovir, as soon as they have any sign that an outbreak is starting, because that will help lighten the outbreak. If they're having more than 6 outbreaks in a year, we want them to consider taking daily acyclovir at a low dose, and that's called suppressive therapy. If they do have an outbreak of those painful vesicles, we recommend a warm salt bath to help dry out the vesicles, and it also helps with pain and itching. We also recommend therapeutic communication. Again, there's no cure. This dramatically changes a patient's life. So we need to make sure that we are being very therapeutic in the way that we're communicating with these patients. Chlamydia. So this is a bacterial sexually transmitted infection. In females, it affects the vagina and cervix. They can have clear or cloudy discharge, dysuria, painful intercourse, and abnormal vaginal bleeding. Anytime a female reports discharge, we need to ask them what color that discharge is. Males, this will cause dysuria, clear or cloudy penile discharge, rectal discharge. Treatment's going to be doxycycline or azithromycin. Azithromycin could be given in 1 large dose if we're worried that the patient's going to be non-compliant with their doxycycline pack. Gonorrhea. So this is sexually transmitted infection that is bacterial. A condom will protect from this STI. Signs and symptoms are copious vaginal or penile discharge. It's often that classic green drip, hence me putting a green drip of paint on the left side of this slide. You're welcome. Bleeding in between periods. Risk factors, so multiple partners, a history of STIs, including pelvic inflammatory disease, low socioeconomic status, age less than 25 years, men with men, and unmarried people. If a mom has gonorrhea and gives birth to a baby, the baby's going to be given those erythromycin eye drops. However, typically now they're kind of giving them to all babies anyway. Treatment is going to be antibiotics. Pelvic inflammatory disease, also known as PID. So this is an infection of the female reproductive organs. It's a complication caused by an infection that's traveling up the tract. So it starts in the vagina and it travels up into that pelvic area. It's commonly related to untreated gonorrhea or chlamydia and other infections that are not sexually transmitted. It can lead to sepsis if untreated. So signs of this are going to be lower abdominal pain, pain during intercourse, dysuria, bleeding in between periods, purulent vaginal discharge, and antibiotics. And that brings us to the end of this PowerPoint presentation. If you have any questions, please send me a Canvas message. Thank you for watching this and filling out your ticket to class. I will see you in class.